Welcome to today's webinar on perinatal substance misuse. My name is Dr. Diane Mish, and I am the Medical Director of Illinois Doc Assist, a free statewide psychiatric telephone consultation service for primary care providers, helping you care for the mental health needs of perinatal women, children, and adolescents. Illinois Doc Assist is working in collaboration with the University of Illinois' iPromote grant to provide this webinar and be available for any perinatal consultations or questions you might have now and in the future. Our contact information will be provided at the end of the presentation. Please feel free to send your questions through the chat box as the webinar proceeds. Doc Assist will answer them at the end. I have no relevant disclosure to make regarding this presentation. The objectives of today's webinar are to learn why screening for substance use is part of comprehensive obstetric care, become familiar with validated pre-screening and screening tools available for your office, increase capacity to care for and manage perinatal patients with substance use, and review the state-mandated reporting of perinatal substance use. Substance misuse in reproductive women is a national public health problem. Greater than 8% of women between the ages of 15 and 49 years old have a substance use disorder in the United States, but less than 50% receive substance misuse treatment. Substance use disorders occur across all ethnic and racial groups, socioeconomic backgrounds, and across the lifespan. The 2012 National Survey of Pregnant Women found that almost 6% use illicit drugs, over 8% drink alcohol, 6% use tobacco, and 50% of those using substances used more than one during pregnancy. Women with substance use issues are more likely to experience poor living conditions, have a history of trauma, have more social, demographic, and health disadvantages, be an older adolescent or young adult, achieve less education, experience more complications from alcohol than men, and become more easily addicted once exposed to the substance. The impact of untreated substance misuse has implications for mother and baby. Women who misuse substances tend to utilize prenatal care late in their pregnancy, have poor nutrition and self-care, have complications with labor and delivery, and more frequently overdose. Babies with intrauterine exposure to substances have greater frequency of prematurity, low birth weight, neonatal abstinence syndrome, and increased neonatal intensive care unit admissions. Alcohol is the second most frequently misused substance in pregnant women after tobacco use. In a recent study, 1 out of 10 pregnant women reported drinking alcohol in the past 30 days. This is especially true of those that fit high-risk demographics like poverty, low education, low access to medical care, tobacco use, and young age, as they may be unaware they are pregnant. At no time during pregnancy is drinking considered risk-free, or is the amount of alcohol considered risk-free. Even small quantities have an impact. Given the fact that women tend to get addicted much faster to substances than men, the problem of staying abstinent from alcohol is challenging. A prospective study found that 96% of women with heavy drinking achieve abstinence in pregnancy with appropriate help. However, at 3 months postpartum, over 50% of them relapsed without ongoing medical monitoring and intervention. Alcohol is the leading cause of preventable birth defects, intellectual disabilities, and developmental delays in newborns, causing 40,000 babies each year to suffer from fetal alcohol spectrum disorder. Key characteristics of FASDs are dysmorphic facial features, microcephaly, low birth weight, disabilities in intellect, speech and language, and learning. There can be attention and coordination deficits, as well as poor judgment and reasoning. The degree of impairment may be mild to severe, but always complicates a child's developmental trajectory. Postpartum alcohol use is also unsafe during lactation. It may decrease breast milk volume and cause high risk of exposure to the infant as it crosses membranes within 30 to 60 minutes after maternal ingestion. Repeated exposure to alcohol in breast milk interferes with growth, motor development, feeding, and sleep in the infant. Now we will look at the effects of marijuana. Prenatal and postnatal marijuana use is associated with high co-use of other substances. Postnatal use is associated with postpartum depression and shorter breastfeeding duration. Studies indicate that 48 to 60% of women who use marijuana continue to use it during pregnancy. The legalization of recreational marijuana use in Illinois is concerning, as THC concentration in marijuana has increased 25 times since the 1970s. No amount of this substance has been proven safe and should not be used to treat morning sickness or stress during postpartum. The half-life of marijuana is long. The range varies from 20 to 36 hours to 60 days depending on length of use. Animal studies indicate that higher concentrations appear in fetal tissue with chronic use. Intrauterine exposure to marijuana affects fetal brain formation by inhibiting normal nerve cell growth. It has been linked to the presence of tremors and heightened startle reflexes in the newborn, and higher risk of substance use and mental illness as the child grows into adolescence and adulthood. It is linked to impaired problem solving, memory, visual perception, behavioral problems, attention, executive functioning, and impulse control issues. Regular maternal use of marijuana can lead to 8 times the concentration in breast milk. The past decade has seen a dramatic rise in the proportion of pregnant women and infants exposed to opioid drugs. More than a 4-fold increase has occurred in 10 years. The increased use in pregnant women mirrors the overall increased misuse of opioids by the general population. Opioids are highly addictive, whether they are illicit or prescription drugs. Dependence during pregnancy is associated with increased risk of adverse outcomes for infants and mothers. Maternal complications include placental abruption, preterm labor, and postpartum hemorrhage. Fetal issues include cognitive deficits, birth defects, intrauterine growth restriction, fetal death, stillbirth, and neonatal abstinence syndrome. The incidence of neonatal abstinence syndrome in newborns born to opioid-dependent women is in a range of 70 to 95% and has increased 400% since 1999. Neonatal abstinence syndrome is associated with an increased use of prescription opioids rather than illicit drug use. It may occur even while a pregnant woman is undergoing maintenance therapy with methadone or buprenorphine, but is a treatable condition. Opioid-addicted pregnant mothers should be educated about the benefits of treatment, as the risk of neonatal abstinence syndrome is higher in women with untreated opioid misuse. Maternal mortality is a significant risk factor during pregnancy in untreated or undertreated women addicted to opioids. The Illinois Department of Public Health has found that pregnancy-associated deaths related to opioid poisoning increased tenfold over the years of 2007 to 2017. The mortality ratio related to opioid poisonings nearly doubled in pregnant women in just 1 year, from 2016 to 2017. Up to this point, I have discussed the risks of substance misuse in perinatal women and the effect on their babies. It is also important to know there is a high correlation between substance misuse disorders and mental health disorders, so screening for both should occur during the perinatal period. Women with both disorders have more severe clinical symptoms, more social issues, and legal problems. They require more specialized care in dual diagnoses programs. Overall, they have lower treatment retention and poor outcomes. There are many contributing factors to this problem, including few specialized treatment programs, less access for women with public insurance, child care issues, and legal consequences for those that admit to substance misuse. If you have cases of perinatal substance misuse and/or mental health disorders and could use assistance, I encourage you to contact Illinois Doc Assist. The first step in changing these poor outcomes is screening for both substance misuse and mental health disorders. Illinois Doc Assist's I Promote webinar on perinatal depression can be found on the Doc Assist website, which will be highlighted at the end of this webinar. In this presentation, I will focus on screening for perinatal substance misuse. Professional organizations generally agree that screening should be done at the first perinatal visit, and follow-up is needed during the postpartum period, as this is a vulnerable and stressful time for women. Screening should occur more frequently if a woman has a history of substance use, as she is at higher risk of relapse. It should occur more frequently if a woman continues to smoke or vape, as it is highly correlated with other drug use. Clinicians who care for perinatal women are in a unique position to address patient substance misuse and advocate for drug treatment. Pregnancy is a window of opportunity to provide anticipatory guidance on abstinence from substance use, to provide screening during and after pregnancy, to provide interventions for enhancing wellness and resilience, and to provide referral for treatment. Treatment for substance use disorders requires a team approach between the primary care physicians who are providing perinatal care and the mental health team who are treating the substance use disorders. If you as the healthcare provider do not have that team approach, or treatment decisions need to be made before that psychiatric referral can take place, please consider calling Illinois Doc Assist for help. The first step in screening for substance use is to ask permission to do the screening. Screening can be done verbally or through screening tools I will talk about in the following slides. The next step is to be transparent about your role in supporting the mother's and baby's health and well-being. Explain your role as a mandated reporter and how you will handle the information provided by the patient. Document these interventions and have the patient sign a consent. The 5 Ps Behavioral Health Risks tool is a pre-screener for pregnant women. The 5 Ps stand for parents, peers, partner, past, and present. It uses 8 questions to look for tobacco, alcohol and drug use, depression, and intimate partner violence. Positive answers need to be further followed up through a validated screening tool that can be done by the patient or by the provider interviewing the patient. Remember, women with substance use can present throughout pregnancy and the postpartum period. Substance use crosses all socioeconomic and demographic factors. It is best to set up a policy to pre-screen at regular intervals, as women are often reluctant to discuss or admit their substance use or mental health problems the first time they're asked. Here are some clinical pearls to help raise your level of clinical suspicion for a substance use disorder, particularly when the pre-screen was negative. Gather more history for the following reasons. If the patient is asking you for controlled substances to help with pain, anxiety, or stress, the patient increases the dose against medical advice, or is highly focused on your increasing their dose. The patient requests early refills on the controlled substances you prescribe her. There is evidence of tolerance. For example, the patient complains that the medication is no longer working effectively. there is any past history of withdrawal. Monitor the patient closely by increasing frequency of visits if she loses prescriptions for controlled substances. She requests a specific agent, route, or frequency. She is purchasing illicit drugs. She talks about taking another person's prescriptions. You discover multiple providers are prescribing controlled substances to her. You notice mood or personality changes, or the patient displays extreme changes in behavior in a matter of minutes, like crying, yelling, pleading, smiling. Intervene if the patient displays signs of intoxication or withdrawal in your office. There is evidence of tampering with the IV or hoarding pills as an inpatient. There is any admission to crushing, injecting, or snorting of pills. You see drug use paraphernalia on the patient's person. On physical exam, you see physical signs of injection, chronic alcohol use, or intranasal irritation. If the pre-screen is positive, or there is suspicion of substance use disorder, the tobacco, alcohol, prescription medication, and other substance use, or TAPS, can be used. The TAPS combines a screening component and a brief assessment for patients that screen positive. It can be self-administered or administered by a clinician. The screening tool is from the National Institute of Drug Abuse and can be accessed through its website. There is an online version available. A resource page will be provided at the end of this presentation for your use, or you can go to the Illinois DOCASIS website for further information. The SBIRT algorithm shown here is one validated screening tool that can be used verbally or electronically to further investigate a positive pre-screen for substance use. Start by asking the pregnant or postpartum woman, in the past, how many times have you used tobacco? And once you get that answer, then move on to alcohol and then marijuana. If the screen is negative, then reinforce the patient's choice and discuss why the pre-screen was positive. If there's any positive response to tobacco, alcohol, and marijuana, then you need to further investigate other drug use, and you need to be specific. So, in the past year, how many times have you used illegal substances like cocaine or ecstasy and get those results? Move on to inhalants like nitrous oxide. Then synthetic drugs like K2 or bath salts. And finally, how many prescription drugs do you use that are not prescribed for you? If the answer is using drugs once or twice, then advise them to quit during the perinatal period and explain the negative impact. If they're using any or more than one drug on a monthly basis, then you proceed with motivational interviewing and then develop a safety contract. If the patient is using drugs weekly or more, then you do motivational interviewing, a safety contract, and make a referral for substance use treatment. Your office or medical center's electronic medical record may already have readily available screening tools for substance use. If you use Epic, there are multiple options. Any of those on the electronic medical record are validated and easy to use. It is important to discuss screening results with perinatal women even when they are negative. Studies indicate that perinatal women are aware if this conversation takes place or not, and are more likely to discuss how they really feel or what is really going on with them when a healthcare professional does so. The benefits of abstaining from substances includes educating about better birth outcomes and optimal health for the mother. When a substance use screen is positive, providers should make interventions depending on how severe the use is. Once or twice use is considered mild frequency. The main intervention is discussing the benefits of abstinence during the perinatal period, including education about better birth outcomes and optimal health for the mother. If the substance screen is positive for use of substances once, twice, or 3 times a month, the frequency is considered moderate. The first step is to use motivational interviewing to help the patient decrease or stop use during the perinatal period. The next step is a plan of safety, which I will discuss in more detail in a few minutes. If the patient reports that she is cutting down or quitting substance use during the perinatal time, offer her referrals for peer support. There are numerous ways she can get help through groups, individually, in person, and online. Consider looking at the DACASIS website or calling us for assistance. A substance use screen positive for weekly or more is considered severe use. First, provide motivational interviewing to help the patient agree to treatment and indicate the need for frequent follow-up visits to ensure the health and well-being of both mother and baby. If the patient agrees, then collaborate with her to create goals and a plan of action, which is called the plan of safety. Then make necessary professional treatment referrals. Now we will discuss some basic principles and strategies to help you do motivational interviewing when the screening tool is positive for moderate or heavy use. Elicit the mother's own description of her substance use and prompt her to discuss the pros and cons. Take an empathic, non-judgmental stance. Listen by reflecting back what the patient is saying to you. Develop discrepancy. For example, if the patient says she doesn't need help but tells you how her substance use is affecting her relationship with her partner or a significant family member, you can say something like, "It sounds like you feel you can control your substance use, but at the same time, it is affecting relationships that are important to you. I recommend that we have you talk with our social worker about this situation." Rolling with resistance is another important key. For example, if the patient refuses to acknowledge that she has a substance use problem, then focus on finding out what her goals are for herself and the baby, rather than your goal as a clinician to have her stop using substances. Support the mother's self-efficacy for change by creating a self-care plan. This will be expanded upon in a few minutes. After you have listened to the patient and followed the steps in the previous slide, it is now time to do some education. Explain any connection between risk behavior and a health complaint she is making. Share information about risks of use and how to lower those risks. It is okay to express concern as long as it is done in a patient-centered manner. For example, you might say, "As your physician, I'm concerned about the effects smoking will have on your ability to carry a pregnancy to term." Ask the patient about what they think of the information, such as, "What do you think about the concern I brought up?" Verbalize several options the patient can choose from to address her substance abuse. An example would be to decrease use of marijuana to once weekly, or decrease vaping to a couple of puffs once a month. Stress the importance of documenting those steps the patient will take to change. Provide her with a document to keep her organized. This document is called the Contract for Safety or a Safety Care Plan. Then provide a list of professional and social supports and resources. Illinois DACASIS can help you through our website or a phone consultation if you need it. Schedule a follow-up appointment at least within a 4 to 6 week period to monitor the patient's progress. The Contract for Safety or Safety Care Plan is available for downloading from the DACASIS website, but you may have a different version on your electronic medical record. You also can create one in your office if that is preferred. The Contract for Safety looks like this. A copy can be given to the patient while another is placed on the chart. The document shows which substance or substances are being used and how often. It then indicates what steps the woman is willing to take for harm reduction, when she will return to see her provider, how she will know the plan is working, which is something you and the patient need to discuss, and possible barriers that could interfere with steps to reduce substance use. If the screening tool is positive for opioid use disorder, it is very important to ensure the patient has access to medication-assisted treatment and available naloxone prescribing for prevention of overdose. It cannot be overstated that post-birth care should include substance abuse treatment and relapse prevention. Postpartum relapse is associated with overdose and mortality in this population and has increased dramatically in the last 10 years. Medication-assisted treatment, or MAT, includes medically supervised interventions using buprenorphine or methadone. It is approved treatment during pregnancy, can address pain management, and prevent postpartum relapse, risk of overdose, and death. Illinois Doc Assist is a MAT consultation resource. You can schedule a time to talk to us through our website or by calling our phone number. What if my patient refuses treatment recommendations? It is important to remember that severe substance use is usually accompanied by mental health issues such as trauma, depression, or anxiety. Through regular screening and/or motivational interviewing, a provider might uncover these issues and offer a mental health referral, as the patient may be willing to seek relief from a mental health disorder rather than substance use. It is also important to determine if an emergency situation is taking place in the office. If the patient refuses treatment, is she willing to reduce the highest risk behaviors such as drinking and driving or using dirty needles? Are there acute mental health issues present requiring emergency psychiatric or medical evaluation, such as suicidality, intoxication, or withdrawal symptoms? Is hospitalization considered necessary? When dealing with patients who have severe substance misuse, it is important to remember when to advocate for inpatient treatment. Criteria include daily or near daily use of alcohol or benzodiazepines. Abrupt halt in these substances can lead to life-threatening withdrawal. Daily or near daily use of opioids, because stopping suddenly can lead to flu-like symptoms and pregnancy complications. Inability to stop using despite engagement in outpatient therapy. If the patient refuses inpatient treatment despite your best efforts, consider whether initiating EMT services from your office is necessary. Be sure to document steps taken, patient's response, and rationale for your decision making. If you are unsure or uncomfortable with any steps regarding screening, interviewing, or intervention of a perinatal patient's substance misuse problem, consider calling Illinois Doc Assist for further help. It is important to balance the risk of treatment versus no treatment for perinatal substance use. Currently, there are more untreated perinatal women with substance abuse issues than those with treatment. Even when women abstain from substances during pregnancy, they are at high risk of relapsing, overdosing, and dying during the postpartum period. Healthcare providers working with this perinatal population can have a great impact on reducing these public health issues by use of ongoing screening, monitoring, and treatment referral, as well as provision of substance use education. The benefits of substance use treatment for perinatal women can be translated by providers to their patients through education. Talking points should include that there is less likelihood of relapse and overdose, which reduces risk of death and improves maternal health and functioning. There are better birth outcomes, which improves the health of the next generation. Engaging in treatment can support ongoing custody of their children and lead to successful completion of the treatment program. Whenever clinically addressing perinatal substance use, it is important to know mandated reporting requirements in your state. In Illinois, providers are required to report substance use at the time of birth. In 2019, 1,066 cases of substance-exposed infants were reported, and 714 were substantiated. Once the report is made, the Adverse Pregnancy Outcomes Reporting System identifies and refers children who require services to the Illinois Department of Public Health for eligibility. If confirmed, Community Health Agency nurses provide case management services to assist with any identified needs, including home visitation. The family is eligible for continuation of services for the first 2 years of the infant's life. The community health nurse provides physical and developmental assessments, education, and makes referrals to services as needed. Finally, I would like to review resources. This slide shows the screening tools and Safe Care Plan discussed today. They are also available on our website. The last resource I did not discuss, but you might find useful for your office. It is a handout on childbirth, breastfeeding, and infant care while mothers are being treated with methadone or buprenorphine. The link can be found on the Illinois DocAssist website. Treatment resources you might provide to your patients are provided on this slide. SAMHSA offers confidential and anonymous information for persons seeking substance and mental health services. They also offer a national helpline available 24 hours, 365 days for individuals with substance use disorders. Illinois has a helpline for opioids and other substances. Links to these resources can also be found on the Illinois DocAssist website. This concludes the perinatal substance use presentation for clinical providers associated with the I Promote grant. You may leave questions for us in the comment section and we will answer. Please feel free to explore our website and call us with any perinatal mental health or substance use questions or cases. We try to respond to consultations in real time as much as possible. We are available Monday through Friday, 9 to 5 p.m. You are welcome to schedule a consultation at your convenience or call us in real time. We are happy to follow up with you as many times as necessary. Our contact information is listed on this slide. The phone number is 866-986-2778. Our website is www.docassistillinois.org. Thank you for your participation, and we look forward to your questions.